So welcome Andreas Hahn. He is my trusted pediatrician in Germany because he is the one who is treating and seeing a lot of Pompe patients, and he's such a mindful colleague, so therefore I'm very happy that he's starting this session.
So hello everybody, my name is Andreas Hahn. I'm a child neurologist from Giessen in Germany, and I'm very sad that I cannot attend your wonderful meeting, but we have a very, very tense personnel situation in our hospital. I haven't seen this in the last 20 years, and please accept my apologies not being with you at your conference. My task is to tell you something about integrative care of Pompe patients. And this, of course, is an easy task. I will tell you something, and the important and very good presentations, they come after me. And why is care a problem in Pompe disease? And to explain this, I will focus mainly on patients with infantile onset Pompe disease, IOPD. And if you compare IOPD or Pompe disease with other lysosomal storage disorders, then you see that the phenotype is really complex, and I will show this in the next minutes. And what is also important to know is that the problems you have in infancy are not the same problems patients facing at age 7 years or 15 years. And Pompe disease is a rare disease, and even physicians treating a few patients with Pompe disease have limited experience. And what is also important to keep in mind, that you will see this also on the next slides, you need a lot of specialists when you want to treat patients with Pompe disease, but keep in mind that if you have a cardiologist who is specialized in his field, does this not mean that he's also a specialist for the heart of patients with Pompe disease? And we still are in the learning phase with Pompe disease, and at least myself, I learn a lot every year. And this means that we have to integrate new knowledge in our care of patients with Pompe disease. So an important issue are orthopedic problems, and our children and also the adults have a residual muscle weakness. And so there is a continuum. You can have a mild, you can have moderate, or you can have a severe muscle weakness. And the problem we have, especially in children, that patients initially have an proximal muscle weakness, but that over time also the feet and the hands are involved too. And many of our patients develop contractures and evolution of scoliosis. That's also a problem, and osteopenia is also something that is underestimated in this population. And what our patients need is an physiotherapy, also by someone experienced in neuromuscular disorders. And we have to take care that they are well supplied with orthopedic aids, ankle braces, and wheelchairs. And sometimes, as shown in these images, you need an orthopedic surgeon for stabilization of the spine. And further big problem we have to face are the facial and the oropharyngeal muscle weakness and the problems related to this. On the left side, you see two children with the facial muscle weakness of a different degree. And so this results in a little bit inexpressive face and not rarely a drooping of the lower lip. And what is also a consequence of facial muscle weakness, these are speech problems. So speech problems, and hope you can hear this, but So this is a famous German song, and without any doubt, this child sings much better than I do. And but this is a typical voice of a patient with Pompe disease. It's a nasal and wet voice and a little bit monoloud. And of course, it's a little bit difficult to understand. And if you meet a patient at a visit, the parents understand them well, but you need a few minutes until you use them to understand the patient. And another problem related to the oropharyngeal muscle weakness are a weak suck and oral dysmotility, and this means that the swallowing and chewing is difficult for the patient, and this can result in aspiration pneumonia, for example, as shown here, and it causes a lot of problems with eating. And what you need to treat these problems are speech, language therapy. It is important to assess the nutritional status of the patient. And in many of them, it is helpful if you have nutritional counseling. Caries is also something that is not rarely seen in these patients, and some of them, many of you know this well, some of them need a percutaneous gastrostomy to secure alimentation in the patient. So a further problem that we see in a lot of our patients are hearing problems. And this is something that is not treatable by ERT. The inner ear belongs to the central nervous system, and this is not targeted by conventional enzyme replacement therapy. And of course, if you have someone who has problems with speech, and then he also has problems with hearing, it is clear that this can hamper substantially the psychomotor development of a patient. And what we have to do is a careful monitoring every few months, and it is important to implement hearing aids early. And sometimes if you have patients with a conductive hearing loss, then you need an ENT specialist doing surgery in these patients. And it's not rare that we see patients who are not supplemented with hearing aids and have substantial conductive hearing loss, and that they improve in their early development when these problems are solved. So going on, and a real big problem in our children is respiratory muscle weakness. Many of these patients have. And what you see in the upper video, this is a boy in a sitting position, and ventilation seems to be normal. And if you look at the child when he's in the supine position, then you see that the breathing is much more difficult for him. And so this is a sign for diaphragmatic muscle weakness. And this is something that is frequent in children with IOPD, and that is something that is easily overlooked. And the problem we have in children is that we have an expiratory muscle weakness. So this means that the cuff is reduced, and that this can lead to accumulation of mucus, and this causes pulmonary infections. So this is one problem the patients have, and the other problem is the inspiratory muscle weakness, especially when the diaphragm is involved. And so this means that exercise tolerance in these patients is reduced, and that they are prone to develop a chronic ventilatory failure or an acute ventilatory failure during an upper respiratory tract infection. And the problem in children is that it is difficult to assess lung function, because the patients are too young, or they are the facial muscles are too weak to perform the classical respiratory function tests like the determination of vital capacity or inspiratory muscle force. So what we have to take care to treat the respiratory situation, and what we need is a physiotherapeutic respiratory therapy for these patients. What we have and what every child should have is a supply with a cuff assist device to allow a better cuffing. And if there is a severe diaphragmatic muscle weakness, then we need an assisted ventilation. And if possible, this should be a non-invasive ventilation and not a tracheostomy. And it is important not to forget the respiratory dysfunction, and the regular monitoring is important. And what helps best is a regular assessment of the nocturnal oxygen and oxygen saturation, and to look for a hypercapnia during sleep. So finally, or not finally, but coming to an end slowly with the problems children have. This is the heart, cardiac problems, and of course, in the beginning of the disease, at diagnosis, we see a prominent hypertrophic cardiomyopathy. So this means that the heart of the patient is extremely thick. And this, of course, is not good for cardiac function. And so these patients are in a dangerous situation because minor respiratory infections, or, for example, anesthesia or minimal changes of blood pressure or heart frequency can lead to a rapid deterioration in these patients. So what we know is that we can treat this hypertrophic cardiomyopathy with some enzyme replacement therapy, and this works quite well. In the vast majority of IOPD patients, hypertrophic cardiomyopathy is a solved problem. Because if ERT is performed, then you can see that heart function improves, and that hypertrophic cardiomyopathy reverses in many of our patients after 10 to 12 weeks of ERT. And so what is often forgotten is that this is not the only problem of the patients. What you can see later during life are cardiac arrhythmias, and I just put three publications in this slide showing that this is a really an issue. 5 out of 11 patients with different forms of arrhythmia, and so this is something you have to keep in mind. And together with some enzyme replacement therapy, you need a pediatric cardiologist, preferably someone who's experienced in this disease. And what you should not forget in the older children is to perform a regular ECG monitoring with a Holter device during the course. We do it once per year. So what we have learned in the last years, or what we understand better, is that the patients with infantile onset disease, not those with LOPD, have central nervous system problem. And one thing we see in the MRI is that the white matter is affected by probably almost all patients with IOPD. And what is a substantial amount of patients develop is a cognitive deficit. and sometimes a cortical atrophy that you can see in the MRI. And what we have also learned is that some of these patients develop a cognitive decline over time. This means they are doing quite well in the beginning, but around school age, it becomes clear that they will have the school problems and will not be able to learn as fast as their peers. And what we have learned is that it is important to assess the cognitive function in these patients by valid tests, and this should be done at least before entering school. And so what you have learned during this presentation is that patients with Pompe disease have a lot of problems. And of course, it is important to choose the correct school. And in the majority of patients, it is necessary that they attend a special needs school. So all these things that I've told you, I think make clear it's out of question that an integrative care of patients with, especially with IOPD, is necessary. And you see on the left list all the problems these patients have. And on the other side, you see also a long list of specialists and therapists you need for a very good multidisciplinary care. And it's without doubt, when you want to have an integrative care, you need 30, 40, 50 persons that take care for your patient. And what you also see here at the bottom of the list, so this is the patient organization, and you are not at the bottom of the list because I think that you are irrelevant. You are just at the bottom of the list, and because I don't want to forget to point this out. And at least in Germany, physicians and researchers always think that they know everything and that they know everything best. And to be honest, it could be that this is not true, and that it is very important to hear the voice of the patient, because the patient is the one with the disease. This is something that is absolutely true. And if you really want to have an integrative care, then it is necessary that your patient has contact to the patient organization and can ask questions often the physicians cannot answer. So in my family, there are some members who state that my learning curve is relatively flat and that I need longer to understand things. So that's why the heading of this slide is lessons I have learned in the last 15 to 20 years. And this is the complexity of the new phenotype in IOPD. And what I've also learned is that it is really important to start ERT as early as possible. And what is also super helpful is when you are doing a so-called high-dose enzyme replacement therapy. And this means that the dosage is much higher than initially recommended. And what we have also learned in the last 10 years is the importance of antibodies against the enzyme and the immunological problems many of our patients have. And what I think also will turn out in the near future is how important newborn screening is. This will improve the prognosis of patients. And so collaboration between patient organization and physicians, this is something that is important to understand the disease. And we also learned the limitations of ERT, and we are quite hopeful that we will now have better enzyme replacement therapies, second generation ERTs. And remember in 2016, we had just one therapy, and this was the ERT with Myozyme, but now we have hope, and you will have some wonderful talks during your conference about new treatment strategies, gene therapy, substrate reduction therapy, and some others. And so if you forget everything that I have outlined during this presentation, one thing that is important for me, that is the importance of experience in treating patients with Pompe disease. So I remember well when I first met Benedikt Schoser, the chair of this session, and this was in 2016, and there was an advisory board on Pompe disease, and they invited specialists in the disease. And I was invited because I treated 2 patients with Pompe disease, 2 children with Pompe disease, and this was enough to be an expert in this disorder. And what I have also learned in these 20 years is that there are in this disease are many possibilities to do the wrong thing, but that it is very difficult to do the right thing at the right time. And this is something we should not forget. And I think it is important that patients are treated in specialized institutions or that they are at least supervised by a specialized center, because monitoring and treatment and making the diagnosis is something that has become so complex that you really need experience in this disease. So coming to an end, I hope I could give you an overview about the complexity of Pompe disease and the many problems patients have to face. And it is absolutely necessary to have an integrative care for Pompe disease, and it is important that these patients are treated by specialists. And I thank you for your attention. And I hope this was a good introduction for the famous presentation you will see or get thereafter. Thank you very much.